Thank you for all the speakers. Online participants, please use the chat for Q&A for your questions and any questions on the floor.
Yeah, I had a question for Holly. You touched a little bit, mentioned potentially phages for fungal infections, but I was interested to hear, do you think that's got more scope? Will that be something that will develop with the program? I know others at Westmead are looking at fungal specific T cell programs because they're often some of our really difficult to treat patients.
Infection is, massive need. But no, we only deal with bacteriophages, so phages that will only infect bacteria. But I mean, that being said, there's, a lot of other, I guess, viruses that would be infecting other microorganisms. I mean, it's just nature's way of controlling and being able to live together within the environment. But yes, no, definitely nothing for fungi.
Andrew's question was when the surgeons went in the last time, or the last relapse, perhaps. The last relapse, we grew E. coli, but interestingly, we didn't find phage. So post-phage, we didn't find phage, even though we saw this amplification for weeks after the phage therapy. When he relapsed a couple of months later, there were no phage in the bone samples that we sent to Westmead.
I was just going to say, I was also chatting with Adam about this case. It's completely puzzling to me because out of all of the cases that we've done qPCR, this patient had the highest viral load we've ever seen. And so when I saw that, I thought, oh, this is amazing. Like they must have been, bacterial infection at that time in that bone, because I know that at the time when you were we were umming and ahhing about whether there was any infection there. I think there was just a tiny little bit on the PET, and then decided to go ahead with phage. So when I saw that amplification response, I thought, oh, well, that's fantastic. There's your answer. There's definitely still infection there. But now, having seen that there was the relapse, there's no phage there on a bone sample that we were able to obtain. It makes me think, was there some other nidus of infection that has caused this enormous amount of viral replication? I do wonder whether there was, I think you said that this patient had cholecystitis. Like, was there? Yeah, I can't fully explain everything, and maybe we will once we brainstorm.
Sorry, this may be a dumb question, but could it not just be E. coli in your gut that's driving that, or does it not cross the mucosa?
Have an infected gallbladder. I mean, that would make more sense than from a, just your naturally occurring E. coli in the gut.
And Holly, I'm looking to you too for expertise. My understanding is that when people have tried to use phage in gut infections, it's very tricky to get amplification for organisms that are in the gut. So we don't get very effective, productive infections with gut infections. Is that right?
Yeah, absolutely. It is hard to get the amplification from, say, fecal samples given a phage orally. Is also hard to find phages, within the bloodstream from oral administration as well. So.
Thanks. I suppose one for Andrew and maybe for Holly as well. What do you think the process was that led to hepatitis following phage? Do you think it's just the immune reaction to LPS, or?
Yeah, I think that's, I guess this Jarrett's-Heimer type concept or paradigm that Holly mentioned. I expect it's part of that, but he gets it with antibiotics as well. So I couldn't really come up with a good explanation, given that he gets it for all sorts of any minor insult. So I guess maybe LPS, but it happened. The Jarrett's-Heimer reaction type, I wouldn't have thought would have happened again on day 12 and day 24.
The phages are eliminated through the endoreticular system, and that includes, in the spleen and the liver. Potentially, there was a lot of clearance with the phage, a lot of clearance with bacterial components, the endotoxin or LPS, that may have sort of tipped it over. But it sounds like everything tipped tip this patient's liver over the edge. So it is very hard to interpret, but it does seem like there was some sort of relationship with the peaks in phage.
I think I was just going to make a general comment about how phages work. And so I guess we think about clinical trials, and there's some phase 2 placebo trials now. I think bronchiectasis is actually quite a good one for that, because there's quite a lot of patients with bronchiectasis or Pseudomonas. We tend to think of this, I had this Pac-Man idea in my brain where the phages go around and eat up all the bacteria. But I think the reality is it's obviously a lot more complex, and it's like an ecosystem in the lung, and it's changing the ecosystem in some way with the benefits there, and it may be temporary. And then there's also this idea of a fitness cost for the resistant bacteria as well. And so giving concurrent antibiotics, as a had a carbapenem resistant bacteria, that in becoming resistant to phages, they become again susceptible. And so the timing of do you retreat with antibiotics around the same time as phages? We tried that for our abscessus patient. Unfortunately, it doesn't seem to have worked. But so I think it's a lot more complex. And I think just finally, it's about managing patient expectations, a bit like FMT and probiotics, a lot of patient interest now. And I think, Paul, you had a case as well. People hear about phages being available in Queensland and elsewhere in Australia. And it's about managing patient expectations that we're very early on, really now understanding, notwithstanding the historical, we've been around for 100 years, but people are just starting to get to understand it.
We one day maybe if we have more money, there is we have all the these PAX gene tubes essentially, so we can do transcriptome on all of the human cases here that have been treated with phages. So this one is potentially one that we could look at, but need the funds to be able to do that.
I have a question for Holly. We both, the patient that I was trying to get onto the stamp therapy, stamp trial, in terms of the timing, like we always look at this as if, we're going to try the standard treatments or everything, and then think about this as more as a salvage or therapy. What do you think, with all the cases that you have seen, the timing of going in early with the phage is a way to go, rather than just wait for everything to happen, like source control? Does that make sense, or should we just go straight in for these complex cases?
And I think if you can treat early, it's always going to be better outcomes. And when I've started to look at, there were some cases there that was more subacute, so not after 2 months, and our quickest turnaround time was 5 days. So we have treated some patients in that more acute setting, and they have all done very, very well. And so I think, absolutely. Unfortunately, we're hampered by the eligibility and the category A indications for a compassionate access scheme for experimental therapies. So unfortunately, there's so many indications for phage, like for a chronic recurrent urinary tract infection, that don't particularly fit in that category. It's the same as we need to try everything first before we can then try the phage. But I think the fact that like these patients are so end of the line when we do administer phage, and we still get that over 80% clinical response, just means that this is something that we should be taking to the next stage.
One thing I learned at your meeting last year, Holly, was about the cost of this. And it actually seemed quite cost effective compared to, say, the drug cost that Will mentioned. For Sphiticol in our high cost drugs committee, we've had $40,000, $50,000 for one patient. And I think Joel said about 15,000 maybe. If you already had a phage service, and then one of us rings up and says we want some phages, it might cost 10 to 15K. I know that can be a bit nebulous, but it actually, if you already had an established laboratory doing this at some sort of scale, then it was actually quite cost effective compared to other antibiotics that we might use.
Yeah, absolutely. I mean, compared to some of those combination antibiotics, it's a bargain. But it is expensive at the moment for research labs to be doing it. So I think we need a cost recovery strategy. But it is a bargain compared to some of the other therapies. And, thinking about these patients, that we had a patient that was referred to us after 3 months in the intensive care with a XDR Klebsiella. And I mean, if we were referred that patient at the beginning of that 3-month journey, the patient could have been out of ICU potentially, and it's cost saving in other ways as well.
Cam?
One of the challenges, as you highlight, is to find ways of moving studies forward when so many patients are salvage patients by their definition. There's been some company work in the US to try and get some off the shelf products ready, particularly, for example, in the staph field, where I think I'm interested in your opinion, because the company spiel is that we feel like there are a generic enough blend of anti-staph phage products that we can have these available, forward deploy them, run placebo-controlled trials without that delay, and therefore move it into a space where we can do more efficient studies of more common problems in clinical cases that are not so salvage. Can you highlight, is that an accurate statement that that we can get sort of common enough anti-staph phages, anti-coli phages, or things that would be manageable to forward deploy? Because I feel like that could move the whole field forward if you could suddenly then get randomized trial space.
Yeah, I mean, yeah, the SNAP, platform trial, they will soon be having a phage arm, and that is a cocktail that was developed, in the Westmead lab. And I think Staph aureus is a great one to be able to do that with, because staph, unlike the Enterobacterales, they don't tend to adapt so rapidly to phage attack. So you probably won't get that change in host range over time to your staph cocktail. So I think that's probably the first, pharmaceutical phage that will become available, will be a staph cocktail.
Okay, thank you so much for all the speakers. And we will be heading into our afternoon break now and coming back for our session 4 in 20 minutes. Thank you so much.